into a lot of headache in primary care, in the OR, in the OBGYN. So having a good understanding of it is paramount. Latassa's already been over the farm associated with headache. I'm going to throw a little bit of that in here from the provider side, but pretty much what she says goes. Brad, what's going on with your hair today? It's not, you look more like Cleaver, Leader the Beaver or something. Is the rest of it still in the back?
Yeah, it's gone.
It's gone?
Yeah. Got a little hot outside, so.
All right. Okay, factors to be determined. You gotta get a good history when you're talking about somebody with a headache. How often you get it determines how aggressively you want to treat it. Duration. Some people claim to have a headache that lasts for years. I think there's more going on than just a headache in those people, but nonetheless, you're going to run into them. And then the intensity is a big thing. So that 1 out of 10 scale is a big thing. The type of pain is important. You need to always ask them, is it throbbing? If it's throbbing, it's vascular most of the time. If it's not throbbing, then that puts them into another headache category that I'll mention later on. So throbbing is now whether that vasculature is due to just a regular routine migraine, or is it due to temporal arteritis or something like that, that puts you on a decision tree whether it's throbbing or not. GI symptoms are important not so much for diagnosing a headache, but for what you need to do to treat it. It doesn't do much good to treat a headache if they're throwing their guts up because of the intensity of the migraine. So you always want to address that as well. And then visual symptoms are quite frequently. About 80–85% of people with migraine will have visual symptoms. Okay. Oops, that's a good one. Other neurological symptoms, other than ringing in the ears and decreased auditory acuity, all of these other ones should raise an alarm that you're dealing with more than just a headache. And that you need to be thinking about scanning these people to make sure that you're not talking about a bleed or a mass or some other problem. So keep that in mind. Photophobia is not a neurological sign or focal neurologic sign when you're dealing with headache. Photophobia is not. Okay? Subdivisions of headache by intensity. When you're describing in the HPI, you need to use one of these terms to let somebody know how much it affects ADLs, activities of daily living. A lot of people with migraines, they have to go to bed. My wife, back in her heyday, she would have menstrual migraines that would last 48 hours. 48 hours. She could not get out of bed for 48 hours every month. And thankfully that's gone mostly. Okay? I think maybe she was BSing me. But I'm not going to go there. Differential for diagnosis, differential for headache, it includes everything under the sun. So no matter what disease they throw out, yeah, that's on the differential for headache, no matter what. Onychomycosis is a great toenail, differential for headache. So it doesn't really help you, but these are some of the things you have to keep in mind here, because if you miss them, you're going to kill somebody. And you're going to do that. Somebody here is going to do that. You're going to send somebody home with what you call a migraine, and they're going to go home and stroke out. So that's why you have to take this serious, and you have to be diligent. If Jordan came over to the clinic over there, well, if she wasn't our student, and I saw her, and she's got this headache, it's a migraine, I have a choice of sending her home with some medicines to treat it, or sending her for a CT, which is gonna cost $600, that she hasn't met her deductible, and that's out of her pocket. So that's, you know, a chunk of month's rent right there. So you can't take this lightly, but you can't blow it off either. Some of these things can kill you. Right? Yeah, Thane.
In that type of situation, wouldn't you just explain the options to the patient and like on the severe side it could be this, or on the lighter side it could just be a migraine, and let them choose? Or
You're still responsible. You can sit there and you can document till the cows come home that the patient, you know, refused to go get a CT, but I'm gonna tell you right now, you will not survive that in court. It just won't. So. International Headache Society, big group of people here. So they've got three basic headaches here: tension, migraine, and cluster. And then headache due to something else. You've got, pick whatever you want. It's like the differential diagnosis. Pick anything, and it's headache because of that. So there are three of them listed there. There are a whole bunch of them listed there. But the bottom line is the primary types of headache are cluster, migraine, and tension. Everything else is secondary. So when you look at that, there you go, primary or secondary. There's a decision tree here. It's very easy. On the primary side, you have those three. On the secondary side, you have to decide, is it an intracranial issue like a mass, or an extracranial issue like some metabolic problem? And let's go down through the secondary causes here. And I'm not going to get on the exam, I'm not being particular that you know these lists. They're intuitive. If I said that, you know, a person comes in with a metabolic issue, then, you know, it's a secondary type of headache. That's all. It's not a classic migraine. It's not cluster. It's not tension. Okay. So you don't have to spend a lot of time going through here. But here on the toxic side, let's look at some of these. The toxic side, one of the biggies is carbon monoxide. Carbon monoxide, you know, especially in this state, poor, rural people are having heaters, kerosene heaters, and open flame type things. That natural gas open flame heaters. You need a carbon monoxide monitor in your home. A lot of people don't have those or smoke detectors in their home, even though you can get them free from any fire department. But if you have somebody that has an issue with carbon monoxide, carboxyhemoglobin is the test you want to run. Ordinarily, it's only a trace amount, less than 1%. Even in heavy smokers, it doesn't get above a couple of %. But then you start winding up with headache once it starts creeping up from there. And the headache severity worsens until you wind up with confusion, coma, or death if it gets way too high. Other toxic type of headaches, solvents. People who work around gasoline, kerosene, that type of thing, and drugs. What drugs cause headache? Every one of them. If you look, no matter what drug you look up on Hippocrates, if you look up side effect, headache will be there. Some of the more common drugs, though, are oral contraceptives are big. Interestingly, oral contraceptives also are used as prophylaxis for headache, that I'll talk about later on. Prozac, Macrobid for your urinary tract infections, and interestingly, opioids. But essentially, you look up any drug, and headache will be one of the side effects. Inorganic compounds, we don't, you know, there's not a whole lot of around us. There's not a whole lot of lead, arsenic, mercury that you're going to get into. Unless you happen to eat batteries, you're not going to get a whole lot of cadmium or make batteries. But you know, these are occupational exposures. And then gases and fumes, all sorts of them, and these are the reasons why we have OSHA. Metabolic headaches, pick a system. Pick a system and you can have a headache related to it. A lot of these are endocrine issues, but they can be, you know, renal failure, hepatic failure. So pick a viscous, and you can have headache as part of its derangement. Which is all to tell you that headache can be from essentially anything. Sometimes you're going to have a patient presenting with headache that you rule out migraine cluster and tension, and you can't find the causative agent. Sometimes you just can't find it. Well, these are the types of things you need to think about. Now, for those of you out there with a little touch of beriberi, a little thiamine works really well, get rid of your headache. Vitamin C, B12, everybody has, you know, plenty of B12. Nice. This is very far-fetched stuff here. But still a cause of headache. Infectious causes of headache, we're going to go over this more tomorrow when we do CNS infections. We talked about meningitis yesterday, viral versus bacterial. Spirochetes and HIV, these are big ones, and often they can be related. You need to suspect in HIV individuals bizarre things, bizarre intracranial infections like spirochetes, like syphilis. Parenchymal infections, kind of going off of the previous slide, when you get down to HIV, there's a condition called PML, and that is caused by a virus. It's like it's got a guy, it's JC, it's not Jesus Christ, it's some guy named John Cunningham or John something another, you can Google it. The JC virus is an opportunistic virus that causes a crazy inflammatory response in the brains, particularly those people with HIV or AIDS, really AIDS. Because HIV is so aggressively treated, you don't see it much now, but PML was a large reason the HIV-infected people died back in the 80s and 90s because of it is an opportunistic virus. If you get the virus, you take care of it. Your immune system deals with it. It's a ubiquitous virus. It's just opportunistic with immunocompromised people. Not just HIV, but bone marrow people and cancer people. Parenchymal infections, you got to think of bizarre stuff like fungi and molds, like mucormycosis and aspergillosis. Parasitic things like going swimming in Lake Eufaula in August with the water temperature high, and you get the water up your nose, and then you get the Naegleria fowleri worm that goes up through your nasal mucosa and eats your brain. At least one person dies every year in Oklahoma because of this parasitic infection. You know what I'm talking about? Okay. I don't think it's Eufaula. It's usually Murray, Lake Murray. Probably has a lot to do with now the alcohol consumption and aspirating this water up your nose. Oddest thing. Probably, yeah. And you don't have to be immunocompromised for this. It can happen to anybody. It happens occasionally to little children, and that's a really sad thing. Once this parasite gets in your cranial vault, it's hard to kill it. I think only one person's ever survived it. It's pretty rare. Amoebiasis, toxoplasmosis, we know about toxo, and then tapeworms are another thing. Tapeworms, another thing. Mass lesions outside the cranial vault and inside the cranial vault obviously are going to cause, obviously can have the potential to cause headache. So you got to think about those. Brain abscess, this is going to cause a headache, right? It's going to cause a headache, pretty much guaranteed, if it's an acute abscess. Now that we got rid of the secondary headaches, let's focus on the things that you're going to see most frequently. And these three right here are the ones we'll focus on. Migraine, most of them are women. Most people with migraine are women. Men occasionally, but most women. Anybody here had a migraine? Who's had a, raise your hand, aye. All right, so maybe about a third of the class. Any guys in here had a migraine? Not one, not a single one. Oh, Dylan, he kind of like, his gender we're not exactly clear on, so we'll just kind of, but anyway, I've had one migraine. I had one migraine about 20 years ago, and you know, I realized that's what it was, and I've never had one since, but it was one single migraine. I mean, it put me to bed. It came on in the afternoon, and that was it. Thankfully, that's the only one I've ever had. Second or third decade of life right now is when people typically start developing them. A lot of women will develop them in their teens as related to periods. So, migraines usually come with a trigger. And that trigger can be, the trigger can be a whole host of things that you see here. In women, high frequency of women, it's their period. A few days before their period, they'll develop a migraine. That's where the hormonal factors come in. That's essentially the only place. They're not associated with menopause or menarche. It's more developed related to monthly cycle. Some odd things like the weather, changing the weather. You know, when the weather front comes in, turns cold, front comes in, turns hot, that's a trigger. So you just never know. The red wine is an interesting thing. I love red wine. Oh, I could put down some red wine, you know, in a socially responsible manner. But then about maybe 15 years ago, I drink a glass of red wine, and it just gives me a raging headache. It's not a migraine because it responds well to just simple stuff, but it's a nasty headache, and that happens a lot, especially in the Asian population. They don't have the alcohol dehydrogenase. So a high percentage of Asians just don't have that. So, what other thing is common in Asians as far as the food thing? What? Lactose intolerant. 90% of Asians are lactose intolerant. Caitlin, were you going to say that? Amy, were you going to say that?
No.
No? Okay. It looked like you guys were going to say something. So over here, essentially, the exact mechanism of migraine is unknown. It's magic. But the treatment for migraine involves constricting blood vessels. So you can surmise that the pathophysiology is dilated blood vessels. Well, they're not dilated blood vessels in your brain because your brain has no pain receptors. The vessels have pain receptors. Remember, they're autonomic stretch. And the dura covering the meninges covering the brain are innervated by the trigeminal nerve. That's somatic. So the pain of headache is thought to be due to vessel dilation. The pain of migraine, or vascular headache, I should say, is due to vessel dilation in the meninges or in the vessels in the brain, but it's not the brain itself. Okay. Here's a little schematic showing this blood vessel over here to the right triggers in the fifth cranial nerve a pain response those things up there in the top, neuropeptide release. Those are released by the ends of the trigeminal nerve. So the trigeminal nerve, we know, goes into the brainstem, right? And there's the trigeminal ganglion. So when this thing is stimulated, the nerves actually release these peptides out here. These peptides are active substances that bring in inflammatory mediators and cause things like vascular dilation. Neurokinin A, substance P, and CGRP stands for calcitonin gene-related peptide. It's related to calcitonin. I mean, it looks like calcitonin, kind of like PTHRP, right? These things have an effect on the peripheral environment. And of course, the central process goes in to activate central pain receptors, and now you perceive pain. The fix is to shrink or decrease the diameter of the vessels. You see right there that where it says 5-HT receptors, 5-HT is serotonin. So what we want to do is we want to block serotonin, and that's one of the treatments for headache. Okay. There are a whole bunch of different types of, if you look at neurologists, they describe about 9,000 different types of migraine. Bottom line is, in the real world, you either have migraine with an aura or without one. That's all you need to pay attention to. Migraine aura is something that the sufferer, perceives usually before the onset of headache. And it's usually within an hour of the onset of the headache. They know it's coming. That's why headache medications are so good in people with migraine with aura, because they can actually take them before the start of the actual headache. You know, it's like the cold sore. When you feel that little burning, tingling here on you start chomping on the Zovirax, and you stop, you don't get the cold sore. It's the same way with aura. If you have a migraine, you want migraine with aura. Without aura, you go from happy to I got a migraine. And once that migraine sets in, the medications just don't work that. I mean, they do work, but not so well. Okay? 25% of people experience migraine with aura. The positive sides, the aura can be a positive or negative. Positive is something happens that normally isn't there. Most of the time it's visual. There's a thing called scintillating scotoma. It's on the subsequent slides, but don't write it down. That's a very common, probably the most common type of aura. It's a visual disturbance. It's not photophobia. Photophobia is when the headache has set in and bright lights are painful. Scintillating scotoma is like, whoa, I'm seeing crap. I know that's not normal. I know it's not real, but they're actually little seizures going off in your occipital lobe. That's the cause of it. Little seizures going back here, little focal seizures going off here in the occipital lobe. Right. There are other things here, tinnitus. People hear music. Usually it's James Brown. I don't know why. No, it's not James Brown. It's Michael Jackson. So anyway, negative is they lose function. When it says inability to move part, inability to move part is you can't move it. A reluctance to move a part is a symptom. is so painful, I don't want to move, is not what this is referring to. This is referring to, my arm doesn't work, and it's not a stroke. Here are some features of migraine. Always the feature is pain at the top. That's 100%, that's a given. And then you go down through there, look at the big ones. Photophobia, phonophobia, the loud noises, you can't stand loud noises, you can't stand bright lights, you're nauseated, you're vomiting. Kinesiophobia is, I don't want to move. My head hurts too much to move. I don't know how many times I've heard that. Diarrhea, usually not 30%. So it happens, but they're usually focused on the throwing up and the not wanting to move. Smell, and I've seen this before, that they have hypersensitivity to smells. And this happens actually in women, the neurological thing, because of the fluctuations in your menstrual cycle. That actually causes hypersensitivity or decreased sensitivity to smells. But this is different. This is an aura, really. This is a scintillating scotoma. The top is, no matter where I look, I see this thing in my visual field, and I know it's not really there. And the bottom thing is an actual scintillating, it's a bright light, it's a flashy thing. Okay, people see, no matter where they turn, they see that image. Okay. Other things like loss, double vision, blurred vision. These things can be, when somebody comes in, let me get it off this thing,
Thank
that
you.
would probably give me a seizure. When somebody comes in and they says, I have photophobia, I have a headache, and I have photophobia, to me that's not bad. That's not a focal neurologic sign. But when they start talking about blurred vision, double vision, I always ask them both. Then I get a little bit more, should I CT this person's head moves up a notch on my ladder if they do. You're gonna have to make a call on that. And it's really frustrating because, if somebody comes in with classic migraine, but they have blurred vision and double vision, crap, I hate to do this to you, but I'm gonna have to scan your head. So, okay. Here are some other less common features here. The vertigo is the one that's probably more common than others. It says 15%, but a lot of people have vertigo symptoms, and that's one of the reasons they just don't want to move their head, in addition to the pain. There are more things related to psyche, and I don't know if this is just a pain complex, but people with migraine, they really aren't happy people. When they're having a migraine, you can be happy otherwise. Okay. You're going to see a lot of headache come into the emergency room. A lot of headache. A lot of times what they're looking for is a narcotic, but it's frustrating. So we'll get into treatment here in a little bit. So you must consider these in new headaches. At least they need to you need to run through these in the back of your mind. Are you confident this is not a TIA or an AVM that's bleeding? Okay. Caffeine produces a raging headache. The absence of caffeine withdrawal produces a raging headache, but it's not. It's a vascular headache. It's not a migraine, but it's just a bad headache for several days. For somebody that says, "Okay, I'm going to quit drinking pop or quit drinking coffee," one of the first things that happens the next day is a headache, and that persists for quite a while. Migraine headache without aura. Here are some of the diagnostic criteria. Pulsating quality. Since a migraine headache is a vascular headache, throbbing or pulsating is uniform in the description. Okay? Headaches that don't pulse are worrisome. Headaches that don't pulse are worrisome. Intracranial masses don't pulse. There's some more diagnostic criteria for headache with aura. One or more of the following reversible aura symptoms. By reversible, they're saying it's going to last an hour or so, and then it'll go away. Most of the time, it will go away before the headache starts. If it's not reversible, that means you're probably dealing with a stroke or a TIA, not an aura. And more diagnostic criteria here. You can read over these. Neuroimaging is not required or indicated when you're dealing with migraine most of the time. Most of the time, people with migraine, you're not going to catch them on their first migraine. It's something they've been living with for a long time. And when you're doing the history on them, you're going to go ahead and get the intensity, frequency, all the information, throbbing, not throbbing. Where is it located? Is it always right here, or does it move around? Something that moves around is good, because if it's always right here, always under there could be that growing tumor. So if the headache is here this month, and the headache is here next month during my period, that's good. Okay. These are the things that you need to do. You need to, if they talk about these things, you need to go ahead and scan them. I mentioned yesterday, it's the worst headache of my life. If Michaela comes in and if I have a menstrual migraine 2 days, or the day before my period, every month. But this month she comes in, she's supposed to start her period the next day or two, but this time, this is the worst headache I've ever had. You scan them. Okay? Mariah, you're puzzled about something here.
I'm just trying to think.
So if you want your head scanned, just go into any emergency room and say, this is the worst headache I've ever had in my life. You will get a scan. Okay, they will scan your head. Okay? The first time it happens, especially anybody over the age of 50, you scan them. Okay? You're scanning them to rule out something bad. You're not scanning them to rule in a headache. You're scanning them to rule, each one of these, you're scanning to rule out something bad. You're not going to diagnose a headache with a scan. Everybody's got that, right? Okay. The treatment, what you do scan, what you do get is, of course, CT without contrast. For the reasons we talked about earlier, the bleeds. Right? Arterial or venous lesions, an MRA, a magnetic resonance arteriography, or angiogram, is something you're going to get in addition. So I'm going to get a CT without contrast, followed by an MRA if I have to. And sometimes you'll get a CT without contrast, followed by an MRI, then followed by an MRA. So it just depends on the presenting symptoms and the person. Mariah?
So if you have a bad headache and you also have like flu-like symptoms, would that be a reason to scan? Because that's what my brother presented with, but they never scanned him.
If you're going to do an LP, if your brother, you know, if there's stiff neck and a raging headache, and on the differential diagnosis is meningitis, if I'm gonna do an LP, then I'm gonna go ahead and get a CT. Okay, and you're doing a CT to rule out something that could be causing an increase in intracranial pressure resulting in the headache. Okay, but a headache with flu, no, I wouldn't normally do that. Now, if they were toxic, probably yes. Treatment, okay, the simple treatment here, you have to, in two things you're dealing with headache, with migraine, is the pain and the nausea. So, first choice is an NSAID or acetaminophen. Excedrin migraine, over-the-counter Excedrin migraine is an excellent migrainoid therapy. But you're not going to convince somebody in the emergency room that that's what you're going to treat it with. But if you suffer from migraines, Excedrin migraine, that's some good stuff. Okay? You want to give them an antiemetic for the nausea, and there are a whole bunch of different options there. I'll go over some of them in just a second. So when you get to the headache is worse, the triptans are the drug of choice. And there are a whole bunch of different types of triptans. There's several drugs in that class. They all work the same. They're all serotonin inhibitors, receptor inhibitors, blockers. It says it later on. You give them at the earliest sign of headache. The sooner the better. You wait 2 hours and you can give another dose. The second dose, after you've done that, you're done for 24 hours. You can't do a third dose. There's 2 doses, 2 hours apart, 24 hours. If you're throwing up, though, you can't take stuff by the mouth. So, sumatriptan comes, Imitrex comes in the nasal spray. You can squirt it up the nose. You can give it subcutaneously in the ER if they're throwing up. Non-oral emetics, so if somebody's throwing up, you don't want to give them much of anything orally. Topical Phenergan is, what they do is they take Phenergan and they put it in this stuff called Oragel. You know, that, like the stuff with the tooth, you know? Or Orabase is what they call it, Orabase. You put Phenergan in that, and then you squirt it on your wrist, and you do like that, and it absorbs through your skin. It works great, especially on little kids. So that's the topical Phenergan. You can also go up the backside with Phenergan. That works good too. Dihydroergotamine, I'm going to be honest with you, I have never used an ergotamine. I have never used an ergotamine to treat headache. Some people swear by these things. Some providers swear by them, but I've never used one, and I don't have any experience with ergotamines. There is a pill called Capergot that is a combination caffeine and ergotamine that's used in the treatment of migraine, but I've never even prescribed that. The one thing that's not up here is Zofran. It's a oral dissolving, an ODT, oral dissolving tablet, 8 milligrams. You put it under the tongue and it just dissolves right away, goes right into the vasculature of the mucosa here. Works great for nausea. Works really good for nausea. It's not as sedating as Phenergan. Phenergan, you're going to go to sleep, which is good because that's really the best treatment for migraine is sleep. Yeah.
Did you get like a rebound headache from Zofran?
You can get a rebound headache from everything. I'll talk about that later on. Everything will give you a rebound headache. Here's some good triptans. Bath salt is a real good one. It comes as an oral dissolving tablet too. So if you have nausea with vomiting, you can take that Maxalt, and it works really well. Axert, I've never prescribed Axert, a lot of people use it, but Imitrex and Maxalt are probably the two biggest plans. So when somebody comes into the ER, let's go down to the bottom bullet point right here. Opioids and barbiturates should never be used, it says not be used, should never be used for treatment of migraine, except as a last resort. And there is no real last resort, because you know what happens when you give somebody 50 milligrams of Demerol in the ER for their headache? The next week, they have a headache again, and they want another 50 milligrams or 100 milligrams of Demerol. And then 3 days later, they have a headache again, they want another Demerol shot. And then they start coming in every freaking day. This is what produces addicts. So if you just make it a policy that I will never give opioids for somebody presenting in the ER with a headache, then you're gonna stay out of trouble. Now it says, except as the last resort, if you have cancer, terminal cancer, and you have a headache, I'm gonna give you whatever you want. But if Ron comes in with a headache, you ain't gonna get an opioid out of me. What do you think they're gonna do? They're gonna go to the next ER. That'll be their problem, not yours. Okay? Drug seekers, I should give a whole 2-hour lecture on drug seekers, because they know how to play the game. They know that if I come in, they know that you're pulling a 24-hour shift in Blackhawk. They're gonna come in during the 23rd hour, when you're the most tired, and the most likely to, I mean, they play some great games. But if you just make it a policy, no, you're not gonna get an opioid out of me, that's fine. That's why I love working at Good Shepherd and over here in this clinic. We have a policy, no narcotics. There you go. Okay, antiemetics. Reglan is a good drug to give with, I'll tell you a good headache combination is IV or IM ketorolac, this is Toradol, it's an NSAID, just like Motrin, and Reglan. That's a good combination. Reglan has anti-dopaminergic effects, it works really well. So, Toradol and Reglan. 10 milligrams of Reglan, 60 milligrams of Toradol IM, or 30 milligrams IV. Works great. Compazine is something that was given a lot for nausea before Zofran was invented. Compazine is usually intramuscular, it comes in the pill, but it's intramuscular a lot of times. I've seen some bad things with Compazine causing tissue destruction, so that's why people sort of moved on. DAT-45 is an ergot, and again, some people use it quite a bit, but I don't. Thorazine is an antipsychotic. And basically what Thorazine is going to do is put you to sleep. It's not an opioid, it's an antipsychotic. And it'll knock you crazy out. And by the time you wake up, the headache will be gone. Haldol and Thorazine, if you want to settle somebody down, you give them a little bit of either one of those and you'll settle them down. Let me give you some bit of clinical advice regarding Haldol. The dose is up to 5 milligrams. It's IV. Don't mess with 1, 2, 3, and 4. Go straight to 5. If you're going to give somebody Haldol, flatten them. Now, getting to what Jordan mentioned earlier about Zofran and rebound. This is something you have to consider a lot. And a lot of people, you see this a lot. People who take anywhere from like Motrin or Fioricet or opioids or triptan, anything can cause the headache. Okay, it worked a little bit, and then an hour later it's worse. It's a rebound effect, and it's true. It really is there. And the only way to address a rebound effect is to just stop using the medicine, stop treating it. It will eventually go away. My wife got into a thing where she was taking Fioricet back when it was pretty popular. That's butalbital, I think it's up here, butalbital and probably aspirin or Tylenol, one of the two, it's a combination drug. And she just had, it used to work, you know, she'd take a Fioricet, headache, migraine be gone. And then 1 month she took them, it didn't work, so she took another one. And then it just snowballed until we finally figured out, wait a minute, you're rebounding. So she just had to bear it and get over it and got away from the butalbital. Any questions about that? Okay. The non-steroidal anti-inflammatories, there are a whole bunch of options here. Again, the Excedrin migraine network that are using. The thing about Toradol, ketorolac, is this is not something you want to give in pill form. It does come in a pill, but this is not something you want to prescribe as a pill. Give it to them as an intramuscular injection or an IV injection, but don't have somebody chronically on Toradol. It should, if you read the warning for Toradol, you shouldn't use it for more than, I think, like 5 or 10 days, or the incidence of liver failure just skyrockets. So it used, when Toradol first came out, everybody was using PO Toradol until these huge side effects popped up. So now, really, if you use Toradol for a day or two, like if you're going to treat gout, that's fine, but don't have somebody, don't write a prescription for 30 days for Toradol. Any questions about that? Triptans, the thing about triptans is you got to watch, one of the things you got to watch out for triptan is that, so they vasoconstrict. That's how they work, vasoconstrict. But they vasoconstrict non-selectively. And they vasoconstrict in the coronary arteries, and that's why people get this chest pressure sensation. Anybody here taking triptan?
My husband takes it for his
Your
migraine.
husband?
My husband takes it for his migraine.
Does he get this warm feeling all over?
I think so. He actually says his headache gets substantially worse right before it gets better when he takes it.
Huh, that's interesting. But a lot of people, they get a pressure like they're having an MI.
Oh, no,
It doesn't last very long, but it is definitely a chest pressure. That's why you gotta watch out giving triptans, or you don't wanna give triptans to somebody with significant coronary artery disease. Okay? The flushing, the warm feeling, it's actually kind of pleasant to, at least to my wife. She takes Maxol, and, you know, she kind of likes it. So. All right, ergots. This is the thing about ergots. Serotonin as well. But again, I'm not going to ask you any questions because I don't use this stuff. Preventative medications, beta blockers. Beta blockers, if you have migraines, I'm going to put you on 10 milligrams of propranolol once a day. I'm also going to talk to you about maybe starting oral contraceptive pills. That works great for migraines. I added this to the slide just before I came down here, so you need to add it to yours. Oral contraceptive pills. Oral contraceptive pills, I'm telling you, they're the greatest things in the world. Not only will they keep you from getting pregnant, they will take care of your acne, they will take care of your cramps, they will take care of your migraine, they'll pay your car insurance. I think it's just amazing what those things do. You know, yesterday in Good Shepherd, I don't know if you guys know this, it was there yesterday, there were 8 patients on the schedule. and there were 7 of you. So the person that they thought was not gonna come in did come in. So I said, I'll go see her. So on the thing here is she was wanting to get her cholesterol checked. Were you there for that? Yeah, you were there for that. Wanting to get her cholesterol checked, and she wanted to start birth control. So I go in there, and she's got 5 kids. Her LMP was the 20th of last month. She hadn't had a pap smear or breast exam in forever. And so she was standing out there. I was gonna come out and get you to go do the pap smear so I could start her on birth control, because she wanted the injection, Depo-Provera. We actually had one in clinic. I mean, I had it in my hand, the box in my hand. I'd gone to the pharmacy. Yeah, we actually have one. So, got a urine sample on her, and she was pregnant. So, anyway. Tricyclic antidepressants, amitriptyline, also called Elavil, Elavil with an E, Elavil, amitriptyline. Amitriptyline works really well too. It's another one of those oral contraceptive pill type drugs, good for everything. It's a depressant, it's an old-time depressant. It, migraine prophylaxis, it works to sleep, it works pain relief. The problem with tricyclics, though, is that if you take them, if you overdose on tricyclics, because my pain is so much, I took the whole bottle, they produce cardiac irregularities and you will die. So it's a bad drug. If you gotta make sure that the person doesn't have suicidal ideation if you're gonna use a tricyclic. Take a break and I'll fix this.